All right. Good morning, everybody. Again, my name is Rocco DiPietro, and you are participating today in what is the first part of a two-part series on the COVID-19 crisis, and that is personal protective equipment, respiratory protection, and bloodborne pathogens training. This is the first part where we'll cover the didactic aspects of these elements, and they will subsequently be followed with a hands-on training session that you have signed up for across the Commonwealth, where we will demonstrate competencies via practical application, wearing, donning, and doffing of personal protective equipment, and conducting fit tests. So this is about a 2-hour session that we'll go through today to cover the basic elements of each of these. So as I navigate the slides, and for many of you, if this is the first time you're on Microsoft Teams, the platform we use, a couple of bits of information. Number one is that I will be muting all participants. So that is to eliminate and minimize distractions and background noises. We have over 34 people in today's session, so I will be muting your microphones. However, as you see on the slide, there's an info bar depending upon the application that you've used to log into today's session that will cover a couple of things. Number one is there's a little camera icon. I have shut off all incoming video, and that is simply to maximize the bandwidth. There's no reason necessarily that we'll have to have video on your end. So we have shut that off. And again, I've muted all of the participants. To unmute yourself, it's as simple as clicking that little microphone button, and you can unmute yourself to ask a question or get clarification, make a statement. Two other ways that you may be able to communicate during today's session. There's a raise your hand icon, a little hand. If you click on that, it will notify me via pop-up that you have a question and we can address that. Or you can use the chat feature. The little text message icon will put into the chat information that all can see. So unlike some of the other platforms where you can kind of message individual participants or the instructor, with Microsoft Teams, those are public to all. They go to all members. So just caution you to avoid any uncomfortable situations. If you do hit the text message icon, the chat feature does broadcast, is visible to everybody. So we will have 5 sections where we'll cover a variety of elements of the training. After each element, I will kind of open the floor to questions and comments. If you have a concern or an area that needs to be addressed, we can do it at that point, and that will just minimize the distractions in each session. So, each section is anywhere from 5-10 minutes to 30 minutes or so. We will spend the full 2 hours. We will break at approximately 1 hour in. So halfway through, we will take a 10-minute break, allow you to get a coffee, stretch your legs, answer some emails. But we will finish at about 11 o'clock, 11:05 has been typical. We've probably run now 30 or 40 of these training sessions, so we have the timing pretty well down pat. So another kind of area that you should be familiar with is you've gone on to TrainPA, the state's LMS, learning management system, to register for today's session. On that same site and any of the classes that are offered, and there are 10 in this series that are being offered across the Commonwealth, under the session tab, there's a resources link. If you click the resources tab, you will see the handouts from today, as well as the handouts that we will be providing in class. So there's some key documents there, as well as a copy of the PowerPoint slide deck as well. So if you do need a copy of the slides, or you want to look through it or share it with others in your organization, you can download the file at that location on TrainPA. Click on any one of the classes, and then follow the resources tab to get a copy of the PowerPoint slides. Just a couple of basics as we get started. So we understand that this is an incredibly dynamic situation, and that there isn't a day goes by that we're not bombarded with updated information, new guidance, changing rules, changing colors. This is incredibly dynamic, and we're all aware that the situation is fluid, and we're cognizant of that as well. So we regularly review today's materials. We've updated them as new guidance has come out, and risk assessments have changed, or personal protective equipment has been refined. But much of what we're going to talk about is rooted in occupational safety regulation that has been long-standing. So while this situation is incredibly rapid moving and ever-changing, much of what we're going to talk about in terms of protecting individuals and workers and the control measures that are in place are long-standing. Personal protective equipment and respirators have been around for a while, so we're familiar with how they operate and what the requirements are. So much of this is 25 or 30 years of teaching and training, despite the fact that they continue to refine the regulatory aspect of this. Another principle of the course, as we learn through today's events, since the primary transmission mode is respiratory secretions and droplets being inhaled by individuals and contracting the virus, respiratory protection is central to our operation. And in order for a respirator to work, I'm not referring to a surgical mask, we're talking about an N95 or greater respiratory protection, that has to have a complete seal around your face. And we're going to talk at great length about how we achieve that seal and why that's important. But as noted by the American Industrial Hygiene Association and many others, it's not simply a matter of creating a safe work environment. We have to work safely within that environment. We can't just provide PPE without ensuring that it is operating properly, that it is working, that it is fitting, because the mask is completely dependent upon a seal. Even a small leak in a respirator will cause failure and potentially infection. So that's why we'll spend a good amount of time, most of the second hour, just talking about respiratory protection and respirator use and limitations, since it's central. Our course objectives really is a basic primer on COVID-19, some of the clinical aspects, really as they relate to transmission. We're not here to talk about medical treatments or serology or virology or epidemiology. We are going to have a little bit of a basic understanding of transmission modes and pathways of exposure, because that really is how we get to personal protective equipment. We will review the OSHA, the Occupational Safety and Health Administration requirements, as well as CDC and Department of Health requirements as they relate to PPE and RPE, respiratory protective equipment. We'll talk about, again, use, limitations, operations, cleaning, fit testing as they relate to each of those pieces of equipment. I mentioned earlier, this is the first part of a two-part series. The second part, when you perform in person or arrive in person at one of the training sites, we will demonstrate use of this personal protective equipment by putting it on, taking it off, doing nursing kind of things and surveying kind of things. We will fit test you on the make and model of the respirators that are provided through the Department of Health cache. And since we're talking about respiratory secretions and the potential transmission of the disease, we will touch on a little bit of bloodborne pathogens at the end for a few minutes, including the use of universal precautions. So that's our agenda for today. Again, 2 hours, about 5 sections, and after each section, we will take a pause for questions and then move on through it. At any point in time, if you do, again, have questions, you can unmute your microphone by clicking the microphone icon on your status bar. You can click the raise your hand icon or the text message icon and ask your question that way. So again, everybody has been muted. All incoming video has been suspended, and the session is being recorded. All right, so let's talk about some real basic awareness to COVID-19. And again, this is not intended to be clinical, but it is intended to lay a groundwork for how personal protective equipment is going to benefit and protect us as we move through the process. Just in terms of some terminology, we refer to this as the novel coronavirus of 2019 because it's new and it hasn't been around, hasn't been identified as an infectious agent to humans before. Sometimes we'll use these terms interchangeably, but there is a difference in nomenclature between the actual virus itself, referred to as SARS-CoV-2, SARS being an acronym for Severe Acute Respiratory Distress Syndrome, CoV being an acronym or a shortened abbreviation for the coronavirus, a series of styles of viruses that we know exist, although this particular one that causes this illness is the second of which. We're familiar with the first SARS incident that occurred a number of years ago. And the subsequent disease that this exposure to this infectious agent causes is called COVID-19, coronavirus disease, identified originally in 2019 in Wuhan, China. A couple of things that we know already, and again, our body of knowledge for SARS-CoV-2 is infinitesimally small in the continuum of disease and epidemiology compared to diseases that we've known and studied for literally 100 years. Here we're talking about a body of knowledge that is, at best 5 or 6 months in length, and in this country even shorter. We know that the virus is contagious and that it spreads particularly easily between people of close contacts. It's got an R naught of, it depends on who you talk to, I guess somewhere between 2.2 and 2.6, indicating that every infectious person will infect between 2.2 and 2.6 individuals, which is relatively contagious on the continuum of diseases. Certainly more so than seasonal influenza, but not nearly as high as something like measles, which maybe 10 to 15 are not. So we do know that respiratory droplets and secretions are the primary source of infection, although we'll see in a minute, not necessarily the only source. Humanity does not have any immunity for the most part. And again, I know we've seen a variety of studies on where immunity stands currently. I know there was a Major League Baseball study that identified kind of maybe it was 0.7% of that 5,000 people not necessarily baseball players, but those in the system, and something in Santa Clara County that may have been a much higher level of baseline immunity now. And I'm sure that will continue to evolve as people recover and we can develop antibodies against it. Coronaviruses themselves are not new. They have been around for a while, and there's 5 or 6 or 7 of them that we know well and have studied in the past. It is the cause, much of the cause of the common cold. Vaccine, again, much disputed, and who knows the short answer as to when a vaccine will be available and how effective it will be. At this point, those are unknowns and certainly not part of our short-term planning. And again, a lot of interesting studies and research and developments and innovation in terms of testing as we move through the continuum of viral testing through antibodies and serology that's continuing to develop and refine. In terms of transmission, again, the primary route of transmission, certainly not the only route, is through respiratory droplets. And again, a lot of our defense mechanisms and controls are predicated on the droplet principle, that is the primary means of transmission. The jury is still out in terms of aerosol transmission and how much those ultrafine, incredibly small particles and droplets are responsible for disease. There certainly is a group or groups that believe them to be a contributing factor. How much of a contributing factor, we're not sure. But there certainly is some amount of aerosolization in any sneeze or cough or in dispersal. There's a range of particle sizes, the heaviest of which obviously will drop out of atmosphere relatively quickly and in a short diameter, hence things like the 6-foot rule. Certainly there will be other particles that are so small that become airborne that may take hours to drop out of atmosphere or may be transmitted great distances away from the source, at least based on current contact tracing and epidemiology. That does not appear to be a strong source of infection. Same would hold true for contact secondary transmission, touching of fomites, contaminated surfaces, the door handles, the cell phone, the computer keyboard or touch screen. Again, I know we've seen WHO recently issued a statement thinking that is not as significant, but that was, again, based on a very limited data set and continue to learn more. But certainly the picking up of the virus from droplets that have been deposited. We know that the virus, while not incredibly virulent, can live on surfaces for hours and days, maybe not weeks and months. But it was completely dependent on substrate and environmental conditions and temperature and humidity and UV exposure. But things like use of hand protection, the washing of hands on a frequent basis really is kind of part of our defense mechanisms there. And then other fluids, just simply unknown at this point about potential transmission sources from other bodily fluids, although the primary route of entry appears to be completely inhalation of that virus, where that virus may exist, and how it gets into your respiratory tract is still fodder for debate and research. In terms of signs and symptoms, again, I think part of this really drives our identification, trying to identify those that may be infected, that are responsible for a significant amount of the infections. looking for fevers. We've seen and will continue to see febrile screening throughout the communities and in workplaces and businesses, trying to identify individuals with a fever of 100.4 or greater, those with cough, shortness of breath, maybe kind of classical signs and symptoms. There is a host of other secondary signs and symptoms, including kind of general malaise, headache, congestion, body ache, even some that report loss of taste and smell as a result of exposure and infection. Keeping in mind that this virus does not exist singularly, we are still bombarded with a host of other infectious diseases and have to kind of differentially diagnose, COVID-19 from a host of other infectious and allergenic agents. So this kind of infograph here kind of depicts some of the common signs and symptoms with COVID as opposed to some other regularly seen diseases and conditions such as the common cold and seasonal influenza. Although we're certainly on the outside of that season, we will be, before we know it, approaching the next seasonal influenza season, and again faced with that kind of decision of is this seasonal allergies, is this seasonal influenza A and B, or is it something else? Additionally, all of our protective measures really are predicated on the risk, and that is the risk of coming in contact with infectious or asymptomatic patients that may be shedding virus through respiratory secretions. So we look at and categorize everybody on this continuum of very low risk workers, those that have very minimal contact with the public or with folks outside of their close circle. Certainly, those that don't deal with confirmed COVID patients, to the other end of the spectrum of those that are not only dealing with COVID confirmed individuals, but those that have high risk because they're involved in procedures that generate aerosols, that generate respiratory droplets and secretions. And everybody else kind of fits in the middle on the bell curve of medium exposures to I really don't have a lot of contact, or I'm certainly not doing anything that would expose me to aerosols, to those such as most of the individuals on this training session that we're dealing with, our constituencies that are delivering healthcare, providing services to confirmed patients within a long-term care center or other allied health profession that just are not dealing specifically with aerosol generating procedures. And in terms of the AGPs as they're referred to, some of the common, there is no definitive list at this point, but some of the common AGPs that we kind of see and would expect to generate a broad range of particle sizes that potentially could be infectious include, sputum induction, CPR, intubation, bronchoscopies, open suctioning, where we know that there's going to be this generation of a high density of particles that can be inhaled that would get deep into the lungs to cause an infection. And in those cases, we'll kind of see a ratcheting up of protective measures beyond what we're talking about in much of today's session. So that's our kind of background as we get started on the journey of PPE and RPE training. If there are any questions, you can certainly pose those at this time. Check the chat box and Don't see anything there, so I will continue then with the next section. The next section really talks about some of the guidance and regulations, particularly at the federal level, as well as kind of the root domains and doctrine that PPE relies upon. So just in terms of guidance that we're looking at, or that is influenced and informed today's training session, OSHA, the Occupational Safety and Health Administration, which is part of the Department of Labor, really is the key agency in terms of occupational safety regulation. Albeit they are not the authority having jurisdiction for many of you. As state employees, much of the OSHA regulations do not necessarily apply. However, they are kind of the gold standard, if you will, in terms of what does the rest of the country do for things like bloodborne pathogen control, or noise exposure, or needle sticks. So OSHA does promulgate regulations and enforces those regulations in the private sector routinely. In terms of the OSHA standards or regulations that really apply to our discussions today, there are three. One is hazard communication, sometimes referred to as the right to know. And there is a Department of Labor and Industry corresponding regulation called PA Community and Worker Right to Know Act. Which essentially says that as a worker, you have a right to know the hazards of the chemicals and materials you're dealing with. In private sector, you may see this manifest itself in what we used to call an MSDS, or Material Safety Data Sheet, now referred to as a safety data sheet. These are documents that describe the hazards, the controls, the first aid, the firefighting, the environmental impact of a particular chemical. So as it relates to sanitization, disinfecting, environment of care for COVID, and how we use those cleaners and disinfectants, referring to the hazard communication standard and providing employees with a copy of an SDS for a cleaner or a disinfectant may inform them of how to protect themselves. Two additional areas, the personal protective equipment and respirator standards. Again, these are long-standing controls, and there's well-established regulation on how they are used, much of which we'll talk about through today's session. And then, as I mentioned earlier, bloodborne pathogens, specifically for those infectious diseases that are attributed to exposure to blood, but that also would include other contaminated secretions and bodily fluids that may have blood as well. So we'll touch on that towards the end. Of course, the CDC, Centers for Disease Control and Prevention, part of Health and Human Services, the key agency providing situational updates and status. They are the agency providing guidance to business and commerce in the United States. They are also the group that's responsible for the risk assessment that is generated, the PPE that we're going to be issuing and that we're going to be discussing today in terms of the ensemble. So that risk assessment is performed kind of across the board for healthcare by the CDC. Two other organizations that we'll discuss, NIOSH, the National Institute for Occupational Safety and Health, part of the CDC that deals specifically with research around worker safety, worker and occupational health issues, is NIOSH. They are not a regulator, but rather the research arm of the CDC, specifically focused on workplace safety and health issues. In our case, they're an important organization because they are the certifiers of respiratory protection. So as we get into talking about respirators and the differences between an N95 mask and a KN95 mask, and a surgical mask and a face covering, that body of research comes out of NIOSH. And lastly is the Food and Drug Administration, FDA, again, part of Health and Human Services, really are providing the clinical guidance on things like testing and serology, things like emergency use authorizations for treatments, for testing, supplies, for even for respirators and the forbiddance of certain regulations as they apply is governed by the FDA. Additional, in order for us to kind of fully understand the layers of defense, it's important for us to describe, or the way we describe this complex situation and series of management tools is through what we in the safety and industrial hygiene refer to as the hierarchy of hazard controls. And this doctrine really is the way we attack any problem in our world. It applies across the board, across a range of hazards. So whether we're faced with exposure to asbestos fibers or electrocution or noise, occupational noise, or in this case, infectious disease from SARS-CoV-2, we employ this series of controls in a specific hierarchy, starting with the most effective means and working down through. So I think of these as kind of individual walls that we build between ourselves and the virus or the outside agent, none of which has to be 100% foolproof, but it is requiring, kind of layer upon layer, something to break through in order to get to an exposure situation and to find a pathway. So let's talk about each of these and how they apply to the current situation, culminating, of course, with PPE. So the example I tend to give in training is over the last 50 years, we've had a tremendous reduction in the number of children that have been identified with elevated blood lead levels. And we know that lead is toxic, particularly to children under 6 years old. And we've had, despite, the things like Flint, Michigan, and in Trenton and in a variety of other communities, we've had a great reduction in the children that have had identified elevated blood lead levels. We didn't achieve that dramatic reduction over 50 years by teaching kids to wear nitrile gloves or by putting signage on windowsills. We achieved that reduction by eliminating the hazard. We took lead out of paints and coatings and coverings and as lubricant. We took lead out of plumbing and distribution systems. We took lead out of fuels and gasoline, which would end up as particulate matter inside of homes. Kids play on floors, they put their hands in their mouths and inevitably would have exposure. So whenever possible, we want to employ elimination. Think of telehealth as a perfect example. If you have a relatively minor health condition, one way to assure that you don't have any exposure is by not going into areas that may have infection. So the use of your iPad or your cell phone, you can avoid exposure through the use of telehealth. Even elimination of routine surveys of long-term care centers and only doing imminent threat or hazard surveys is another example of controls that are in place designed to minimize exposure. Maybe contracting services. We've seen a number of our housing authority clients, for example, that when a confirmed COVID patient or resident exists, that they'll contract through a professional cleaning organization and not use their own staff, minimizing exposure. Again, that's not always possible. There are inherent risks in what we do, and there are going to be, but it is one of the most assured ways we can eliminate, most effective ways. The next in the layers of protection is what we refer to as an engineering control. These are the design changes, the as-built environment, things like plexiglass barriers, isolation rooms and negative pressure rooms, separate waiting areas, drive-through services are examples of engineering controls. We do know that the virus kind of binds to particles, and those particles can be inhaled. So recommendations to increase the amount of fresh air, to ventilate, to maybe ratchet up your fresh air intakes from 10% to 25%. Increase air filtration ability. So filtration is measured along the MERV scale, MERV. If you do this as a homeowner, you may buy a MERV 3 or a 4 filter for your home ventilation system. Now, we'd like to see that as a 13 or higher where possible. Increasing the MERV value increases the filtration, the capture of particles. You may not stop an individual virus, but as we'll see when we talk about respiratory protection, you don't necessarily need to have a filter pore size small enough to catch a virus in order to stop transmission of disease. Another area in the chain that we'll kind of move down through is the administrative controls. These are the work practices, the rules, the policies, the training, things such as the occupant restrictions, whether it's capacity or large group gatherings. We went from no more than 10 to no more than 25 to no more than 250. Those are all designed to minimize exposure. Again, they're not foolproof, not as effective as elimination, but part of our defense mechanisms. They're part of those layers that we're building to further minimize exposure. Maybe elimination of aerosol generating procedures, cancellation of elective surgeries, use of signage. You can't go to the grocery store without being bombarded with new signs and one-way paths and separate entrances and exits, and the use of registered disinfectants, knowing that disinfectant you're using is effective at killing the SARS-CoV-2 virus, which in general sense is a relatively easy virus to kill. It is not incredibly difficult. It's not C. diff. It's not Ebola. It is, 20 seconds of hand washing with soap and water is enough to break the lipid layer on the envelope of the virus. So it is not terribly difficult to kill, but does require some proactive measure if you want to eliminate it quickly. And then the last in this hierarchy is personal protective equipment. It is the last because it is the least effective. It is the last barrier between you and the bad thing, whatever that bad thing is, whether it's noise, it's electricity, it's a fall, it's a chemical, or it's a biological. In this case, it's a virus. So we'll talk about personal protective equipment as it relates to healthcare, in terms of body covering, in terms of respiratory protection. But as we'll see, it requires a significant amount of user intervention. It's not as simple as just passing it out and expecting it to work. There are things like fit. There's things like doffing procedure that have great implication into how effective that PPE is going to be. So it is not the first choice, but inevitably folks want to move down this continuum more rapidly. If I said to you, how would we control this person that has excessive noise exposure, many of you would give me a response of, we would give them hearing protection. And while that may be one of the things we do, it shouldn't be the first thing. We should ask, can we eliminate this? Do we have to even do this? And then things like, can we engineer it or administratively control it before we administer personal protective equipment? Any questions so far on what we've covered? Okay. All right, let's move through section 3 and talk about personal protective equipment. One of the central themes of today's session is really to have a fundamental understanding of the equipment, the ensemble, what we're providing or what you're required to wear, and how it works to protect you. All personal protective equipment starts with what we call the hazard assessment. This is a requirement from OSHA that is very commonsensical. I mean, there's a variety of things out there to protect your hands. The same gloves that you're going to wear in a long-term care center to protect yourself from COVID exposure is not the same things you would wear if you were a welder. Or if you were handling plate glass for a living. So we do know commonsensically that, for every style of hazard, there's going to be an appropriate type of personal protective equipment. We'll get into the nuance on the ensemble specifically and who certifies or what standards that equipment needs to meet. But the selection is not random. The selection is not haphazard or ad hoc, but rather thought out, planned based on the hazards that exist and the risk. So when we talk about the PPE that is supplied, things like training need to accompany that. So we don't just say there's a box of PPE over there, figure it out. OSHA says that you have to provide training to your employees as how to wear such equipment, what the limitations are, how often to change it, how to clean it, how to ensure that it fits appropriately so that it does what it's supposed to do. And that is rooted in the OSHA standard, that 29 CFR, which is the Code of Federal Regulations, 29 being the volume. If you think of this as those of you that remember, before the internet, there were these things called encyclopedias. It would be a range of books. We would pull out, book number 29, and that would be all of the federal regulations that dealt with the Department of Labor. Everything from pensions to overtime to worker safety. Inside of that book, there'd be a chapter that dealt with a particular letter. Maybe it was the letter J. Well, in our world, 29 CFR 1910 deals with occupational safety regulations that apply to general industry, which would include healthcare. And then a specific entry would be .132, which deals with personal protective equipment. So when we read where are the regulations for personal protective equipment from OSHA, 29 CFR 1910-132 deals specifically with that standard, as opposed to separate standard that deals with personal protective respiratory protection, 134, or something that deals with lockout, tagout, and control of hazardous energy, or hazard communication, which all have separate entries. In terms of COVID exposure, our hazard assessment, or the hazard assessment that's been issued by the CDC, is really based on a couple of elements. One is, what is the assignment? What is that relative risk in terms of contact with patients? What is the task? A sublayer of your assignment is the task. It's one thing to be a nurse doing rounds. It's another to be a nurse on an intubation team. What is the status of the patient? Are they confirmed COVID? Are they suspect or presumed? Are they tested as negative? And what is the personal protective equipment or uh, um, relative control in place on that person? Were they inside of the 6 foot circle? Were they wearing a mask? And all of that can influence the ensemble that we're talking about. But from a CDC standpoint, this is an important slide, and one that's in the handout packet, and one that we'll provide to you at the session. This is the ensemble that is promulgated, if you will, for most of you as you perform your activities inside of long-term care centers. You'll be afforded this ensemble, and we're working with equipment provided by the Pennsylvania Department of Health through an equipment cache that includes some variation of this. And the image on the left, the preferred ensemble, kind of from the top down, includes a face shield or goggles, each being equivalent, which would designed to provide protection against virus coming in contact with the mucous membranes around your eyes. That still is a potential transmission source. So we need to cover that area from droplets. And a mask itself won't do that. So a face shield or goggles, non-vented goggles. The face shield being somewhat preferred, we'll talk about in a little bit, but either is deemed acceptable. An N95 mask, but when you're dealing with confirmed patients, and again, there is some leniency there. There's some variation. We'll talk about alternatives, but an N95 or higher, and we'll talk about a variety of types of respiratory protection that are even better than N95. An isolation gown, some kind of a body covering to protect, the outside of your clothing and skin from collecting deposits of respiratory secretions, which later can be contacted and transferred to your respiratory tract or breathe in. And then one pair of clean fluid-resistant gloves. And again, we're talking one pair. This is not those of you that went through Ebola training. This is not double gloves. This is not taped seams. It's a relatively easy to adapt type of ensemble. The acceptable alternative really deals with the face mask because of supply chain shortages. And I have a slide later, and we'll talk about kind of how things have changed. I've been in this business since the early 1990s. And there's things I've said in the last 3 or 4 months that I never thought I would ever say. Like, yeah, it's okay for a nurse to wear a bandana on an infectious disease floor, or yeah, it's okay to bake your N95 respirator in your oven for 30 minutes at 157 degrees to disinfect it. Those are things that were unheard of 3 or 4 months ago, but now are absolutely commonplace because of the situation that we're in. 2 areas that we just have to kind of look at that come up routinely is the area around the head itself. Head covering is not included in the ensemble, but I could absolutely understand why individually an organization might choose to employ that. These deposits and secretions can be deposited. Most people are a little more fortunate than I to have a little more hair that would collect those deposits. You can touch your hair later, touch other surfaces or breathe that in. So a head covering you may see employed at the sites, the locations, long-term centers that you have to go to, as well as foot coverings, booties, or some type of shoe or foot protection, even including many sites we see have essentially a little kind of a mat or a tray, no deeper than a cookie tray, with a little bit of a disinfectant, bleach and water solution that you have to step in as you leave the COVID wing of a center or a patient room as a way to prevent transmission and tracking a virus outside of that area. Booties present a different kind of problem of trip hazards and slips and head coverings, may be difficult to get. They can be disposable, they can be reusable, but you may see either of those employed out in the places that you may go to survey. In terms of each of these types of equipments, we're just going to kind of review them briefly so you have an expectation as to what is provided and what is acceptable. In terms of gloves, we have a wide variety of gloves. FDA classifies gloves based on their performance. So you may see a range of gloves, but the general patient exam glove, a nitrile glove, a vinyl glove, neoprene, all are going to be acceptable from a fluid resistance standpoint. What we're really trying to do is find gloves that are comfortable, that are easy to wear, that are the right size, that allow you to do your job. That's critical while still providing that level of protection. So, I think the only thing we worry about here is latex. There is a significant portion of the population that is latex allergic. Some are severe. So you don't see a lot of latex. You don't see a lot of powder gloves anymore. Most of the cache is filled with nitrile gloves, these kind of blue or vinyl gloves that we use, one pair. Again, what we want to do is just make sure we're not cross-contaminating, make sure we're not picking up virus, particularly when you're into patient care and contact. We do see a number of sites that will not wear gloves. They just see too much secondary transmission. It's kind of before COVID, you go to the Subway shop, sandwich shop, and kid is making my sandwich and he's got his gloves on and he, makes my sandwich, and then he wears those same gloves and grabs money out of the cash register and then picks up the phone to take the next order, all while wearing the same gloves, kind of spreading everything all over the place. And folks don't tend to wash their hands if they have gloves on. So while it may protect you, it doesn't do a lot to prevent secondary transmission. So just kind of be alert for that. Again, you have to be able to do your job in that PPE. And in speaking of doing your job, in terms of body coverings, again, we'll see a range of body coverings, all designed to prevent kind of that fluid deposits onto the front of your person, from coming in contact with people that may be dispersing fluids through coughing, sneezing, yelling, talking, spitting. And what we're trying to do is minimize that contact. So the normal cache includes an isolation gown or some type of body covering, particularly the frontal area. Maybe an apron, sometimes in combination, an apron over a gown if all you have is fabric, like launderable gowns that don't provide a lot of fluid resistance or liquid penetration or barrier. You may wear a vinyl apron over the top of that as a secondary protection. Included in the ensemble, and one thing we'll talk about when we're in person, is the use of coveralls, a Tyvek suit, which is a full body covering, which is included in the cache as well. So when we demonstrate PPE, we will kind of do both. One time we'll wear the gown, one time we'll wear the coverall. And you will see the difference. Not only is it more difficult to get on and off, but it greatly impedes your ability to work. It becomes difficult. It's hot. We've seen that with face masks. It's uncomfortable. And as a result, productivity is lower. If you're a nurse or an aide providing care and you got to do it in this PPE, it will slow you down. In the normal counter to that in our world is to add more people to the job. So if it's going to be slower, you're going to need more breaks. You're going to have to hydrate, put more people on it. But now that's counter to our administrative control, which is limiting exposure. So, we're not adding more people. We have to work smarter. I mentioned this in training, and a gentleman who was moonlighting at a hospital in the ICU on the weekends said, he had a full ensemble coveralls, a powered air purifying respirator, and to enter into the room to take care of the patient. This was early on in late March, early April. And he said they gave me meds for 8, 9, and 10 a.m. And then they gave me meds for 1, 2, and 3. And he said, well, let's combine those so that I don't have to get dressed and enter every time because it's incredibly difficult. So there may be some managerial things we can do, but you should prepare for lower productivity, for slower response, for more deliberate action. In terms of body protection, some of the standards that we want to meet, is, again, we're looking at things that are going to prevent splash, that are going to minimize the us touching clothing, durability. They have to be able to last a shift, at least in some cases a week. They have to be comfortable and allow you to perform your job. In terms of how we gauge fluid resistance, there's a number of standards and consensus guidelines out there, so that we'll know that the gown that you're assigned, it happens to be an AAMI level 1 gown, which is kind of the minimum. This is provide a minimal barrier. It comes off as relatively flimsy, but it will provide fluid resistance. It's not the same gown you would wear if you were a trauma surgeon and had your hands in a body cavity for 8 hours doing organ transplant, because blood would penetrate, fluid would penetrate through eventually. But for walking through a nursing home or providing a survey, interviewing people in an administrative area, that's more than adequate. So we'll look for the equipment you're being provided to meet these standards, to have a fluid protection rating that the Tyvek does, that have that liquid barrier protection that the gown does. In terms of eye and face protection, again, I mentioned the ensemble includes one of the other of these, either a face shield, and again, this is simply polycarbonate, a plastic that fits, snug to the head, provides coverings for your eyes, and this provides added benefit of covering the mask. So it does provide a secondary barrier, to the outside of the mask, and barriers work. I mentioned engineering controls. I go to the local convenience store to get gas or whatever, and I go in and early on, this guy couldn't afford or didn't have access to plexiglass, so he went to the local hardware store and dropped a shower curtain, between the cash register and the public, which worked. Was actually funny. It had like dolphins and seahorses on it. It was probably all he could get, but it worked. Provides that barrier. So the face shield, which is included and will be provided to each of you during the hands-on, it's just a piece of plastic with an elastic band and a little bit of foam around the head, but it does provide that protection. A mask or some kind of facial covering. Again, we'll talk about respirators here shortly, but we got to have something covering the face, or goggles. And again, if we're using goggles, we're talking about non-vented goggles. These are nice because they're very resilient. They're durable. You can take them off, dunk them in a bucket of disinfectant. They're rigid. They're resilient. They're easy to decon. But not as comfortable to wear. Simply a trade-off. We'll close this section with kind of the sequencing. And again, this is really the purpose of the hands-on, so I won't go through it in painstaking detail. But again, this is included in the handouts on Train PA. Couple of things that are important here. In terms of donning, the wearing of the PPE, don't think of sequence as critically important. It's far more important that you're wearing everything and you're wearing it appropriately and correctly than that you've put it on in the right sequence. So it doesn't matter to me as a professional whether you put the gloves on first or last. What matters is you're wearing the gloves. So what we see is that there's a prescribed methodology, starting with the gown, moving to the mask or respirator, then your face shield, and then your gloves. But what is far more important, again, is that you're wearing it all and it is correct. So what we see is where folks are dressing out, and maybe it's a clean change room, it's an entrance to where you keep your PPE, a full-length mirror. It's okay to cheat. It's okay to have this posted, to have pictures. When we did Ebola, we would have a fully clothed mannequin or a picture of somebody at each stage that says this is what you should look like at this stage. Your respirator on the right way, tightly sealed. Your gloves connected at the wrist. And again, that's the only area we kind of get a question is it gown over gloves? Is it glove over gown? It really doesn't matter. The short answer is in most instances, the gown over the glove provides a sufficient connection point here at the wrists to prevent skin exposure. If you're doing a lot of reaching and don't want that gown to ride up, you can actually punch a hole through many of these gowns and kind of assure that you get a connection. If you're dealing with a lot of fluid, you're doing baths and bathing or dealing with a lot of liquids and saline fluids, you would wear your gloves over your gown, because then any fluid that you got on your hands would run down and onto the gown and not inside like a gutter. So again, sequence not terribly important, much more important that you're wearing it correctly. That's not true, however, in terms of the removal. The doffing process is sequence dependent because we're trying to minimize secondary contamination. So the doffing sequence starts with your gloves, and we will practice this technique. There's a couple out there of removing your gloves without contaminating your hands, so that we're assured as we go through the rest of the process, we didn't dirty something that was clean, or we didn't touch something that was dirty. We start with the gloves because they're theoretically, we would believe, the dirtiest part of the ensemble, so we get rid of them first in the process. We then move to the goggles or the face shield, and again, key points here, grabbing it from the back. Again, we're assuming frontal contamination, so you grab it from the back, either at the strap or whatever, with your head slightly tilted to the forward and down and away from your face. You don't want to do is grab the bottom of it and pull it over your face, thus creating it right into your breathing zone or contaminating other areas and getting stuff airborne. So everything is kind of done down and away from your face. Then comes the gown, inside out. These gowns or Tyveks tend to be just kind of zippers or ties. Key here is kind of keep it in a small profile. We don't want it flying around, flapping, creating splash or aerosoling anything. And then ultimately you're going to dispose or launder that. Then comes your respirator last. There is a kind of a quiz that comes at the end of the or at the beginning, of the hands-on session, or we'll review this material. And I can tell you, kind of one of the things we want to make sure is that everybody knows that's the last step in the process, is removal of your respirator, so that if anything was generated, aerosols, through the removal process, you've been protected. So it's the last thing to come off. And again, concept is back of the head, straps off, away from you, down, not over your face. And then the last step technically is, wash your hands. And that's an important step no matter where you are in the sequence. If you mix it up, if we mess up and I grab the outside of the face shield or I touch the outside of my mask, it's not the end of the world. Doesn't mean you're going to get an infection. It simply means we stop and we wash our hands at that point. So you can stop at any point if you think you messed it up. Wash your hands, hand sanitizer, and then just continue on with the process. We want you to be comfortable in that. All right. I was 2 minutes over my estimated time, but for now I have 10:07. If there are any questions, you can ask them at this point. If not, let's take a 10-minute break. And it just turned to 10:08, so we'll reconvene at 10:18. Rejoin. Now, you do not need to cancel, close, anything. You can just kind of walk away. Everybody has been muted, and all incoming video has been shut off. So I will rejoin you at 10:18. And we'll finish out the last two sections and get done right about 11 o'clock. right, everybody, welcome back. Can I get just a quick comms check? Can you tell me you can hear me? You can see the screen says Section 4 respiratory protection. You can use the chat box or you can.
Yes. Yes.
Excellent. Thank you so much. Appreciate it. Thank you. Thank you for using the chat, letting me know. Excellent. Great. Very good. And I did put my contact information in the chat box if you do need to get in touch with me after the session. That's how you get in touch with me through one of those means. All right, so let's continue then and close out. Section 4 is the respiratory protection standard. So let's talk about respirators. And as we start to talk about respirators, let's kind of first start with the way that we breathe, right? So in terms of the mechanics of respiration, how this works, we're probably all familiar, but your body needs oxygen to survive, so it's instinctual to take air in through the lungs. Normal atmospheric air contains about 20.8% oxygen. That air ends up through kind of a mechanical series of pipes, but terminate deep in the lungs at these little tiny sacs called alveoli, where blood circulating near the surface of those picks up oxygen molecules to take those to organs that are necessary and kind of dumps off carbon dioxide, which then gets expelled as a waste gas through your body. So it is this process that every human being goes through as a way to sustain life. Some things that will interfere with that process, however, would include the lack of oxygen. So if we had an atmosphere that didn't have 20.8%, maybe because of a confined space or something that consumed the oxygen, a fire, heat, being in the in the desert, in the midday sun, will affect your ability to breathe. Chemicals in atmosphere, toxins, asphyxiants. Unfortunately, every year people pass away because of carbon monoxide poisoning. Even in the presence of oxygen, your body has an affinity for carbon monoxide, and your blood will pick up that instead of oxygen on the receptors. So you essentially can be poisoned with carbon monoxide in the presence of oxygen. Blockages, particulates, or we've all worn surgical mask now for extended periods of time, and inevitably you've heard somebody say, maybe yourself, it's difficult to breathe, it's uncomfortable, a struggle, which is one of the key principles of respiratory protection and why we have some of the protocols in place that we do. So in terms of respirators, a couple of classifications of respirators. Not all respirators are the same. First thing we do in terms of kind of categorizing them is we talk about what happens inside of the face piece. What happens in that little space between your nose and mouth and the respirator itself when you are breathing, because it's a key indicator as to how the respirator is going to perform. So these respirators on the left side of your screen, including the N95, are what we call negative pressure respirators. So when you breathe in, you create a negative pressure inside of here, which means that air wants to rush in as you breathe in. The principle of operation really is that this seals around your face incredibly tight, and so that no air can get through, thus forcing air that you breathe in when you create that negative pressure to come through these filters. And in the case of an N95, the entire face piece, it's referred to as a filtering face piece respirator because the entire face piece is made out of a filter membrane. But on these elastomeric respirators, this is a half face and a full face, Air is designed to come through these filters and be purified in some way. In the case of a filter, it's simply removing particulates. But in the case of a vapor, like an organic vapor, gasoline, toluene, acetone, this cartridge is filled with activated charcoal, and that will absorb those organic vapors. So it's not necessarily filtering in a mechanical sense. There's a chemical absorption that takes place. So depending upon what the contaminant is, would dictate what the filter would be. And the respirators on your right, these are positive pressure. So whether it's an SCBA, self-contained breathing apparatus, this bottle contains atmosphere, bottled air. This is what's called a powered air purifying respirator, and there's a filter and a fan. But in both cases, air is pushed into the facepiece, either through pressure or from a fan. So if there's a breach in the seal, if there's a leak, air is pushed away, as would be contaminants. So they're inherently safer because you don't have that negative pressure. You also don't need a seal, so we don't need things like a fit test that we're going to talk about. The air purifying respirator, again, works on the principle that this entire facepiece is made out of multiple layers of various materials, including polypropylene fiber, and it works as a catch, as a sieve, to stop particulates from coming through the entire facepiece. Clearly not designed for an oxygen deficient atmosphere. Really were never designed to be durable and reusable. They were meant to be disposable, cheap and easy to wear, kind of a respirator to protect you against a range of particulate matters that wasn't necessarily incredibly toxic or dangerous. Two other kind of classifications you might hear as we refer to respirators: the tight-fitting respirator. Again, both of these work on the premise of creating a seal around the face and being tight, and then using that seal to direct air into the facepiece, or a loose-fitting type of hood that is, pressurized by a positive pressure. And in terms of levels above an N95, we say an N95 or greater. One of the greater would be the powered air purifying respirator. And again, you may see this in acute care hospitals and in some industries where we have those aerosol generating procedures, because here we're not dependent on a seal, but rather there's a motor and a fan and a battery, and this fan draws air through that same filter, pushes it up the tube and into the hood or into the helmet, again, creating a comfortable atmosphere to work in. If you had to work 8 hours, it's not difficult to breathe in here because there's air being pushed into the facepiece. It's cooler in the summer, and you don't have to shave, which is one of the disadvantages of a tight-fitting respirator for people that have facial hair. However, there are disadvantages as well. They're big, they're bulky, they're difficult to decontaminate, they're noisy, they require batteries and maintenance, and they fail. So it isn't, a perfect solution, but it does afford a greater level of protection. All of the filters for any of those air purifying respirators are contaminant specific. They're designed for a specific style. So the filter that you would wear, like this magenta filter, is the HEPA filter, particulate filter. It is not going to be good for painting a car. It's not going to be good for working at the sewer plant where you have a chlorine gas or a mercury vapor. So it is kind of chemical specific. There's change out schedules. There's times from when they're open that they start to do work For example, the activated charcoal, as soon as you take the shrink wrap off, it's starting to absorb things. Even without you breathing, it's absorbing. So they have schedules to be replaced on. And of course, they're NIOSH certified. They're not just arbitrarily based on a manufacturer. They're tested by NIOSH. A couple of filters, and when we talk about particulate filters, we'll see this in greater detail, but we've heard the term HEPA, high efficiency particulate air filter, and that's a filter that's 99.97% efficient at removing particles 0.3 microns and larger. And we'll see that in the next slide as well. NIOSH doesn't use the term HEPA anymore. We use some of these other terms we'll see in a minute. But a HEPA is the highest level of respiratory protection, the greatest filtering that can happen. And even that's not 100%. So even though we call it the 100 series respirator, it's like the ivory soap of respirators. It's 99.97% effective. In terms of Urensemble, again, a filtering face piece, sometimes referred to as the dust mask, an N95 respirator. It is NIOSH certified. It's a legit piece of personal protective equipment that has been tested and validated. It is tight fitting, so we know it has to have a seal. It is air purifying, so we know that it is filtering, not adding atmosphere, not adding oxygen to the atmosphere. And we used to say disposable, single use. We'll get into that in a second because that's not true anymore. When you look at an N95, and there's probably about three major styles of N95s out there from a variety of manufacturers. The standard, this happens to be like the cup molded design, kind of designed to fit around the face. Going to have a couple of straps, but what you'll see on it, some markings, and those markings are important. There's alphanumeric N95, we'll talk about that. Model, the NIOSH approval number will be included, assuring you that it has been tested, and then a lot or manufacturer number. And when we talk about the components of an N95, well, there are those three styles, and they all kind of may work a little bit differently. Some basics. They're all going to have a nose clip, something that forms to provide a seal in the area around your nose and cheeks. This is the primary area of failure. So they have that metal band that kind of conforms, that has to be formed to fit in that area. They will have a two-strap system, an upper and a lower, one that goes above the ear, one that goes below the ear. They will have a sealing material of some kind. Sometimes it's the same filter material, just pressed and shaped and formed differently. Sometimes it's a separate product attached to it. And they may or may not have an exhalation valve. This is important discussion because you got to remember these dust masks, N95s, have been around for dozens of years. The primary use was either in healthcare or in construction, from construction debris and just general nuisance dust, where we were not worried about the human being the contaminant. So they have an exhalation valve, some of them do, which is a one-way valve that allows the free flow of air out of the mask, making exhalation a lot easier. You don't have to force air through the filter membrane and build up additional moisture. It gets air out of the face piece faster. However, in our world now, knowing that we are in a situation where we may be asymptomatic carriers, hence face masking universally, we're asking people to have a covering over their face to prevent that spread of respiratory droplets. NIOSH has indicated that this exhalation valve does not provide a barrier, so it is not recommended as a general face covering. So if you're, see this in the grocery store, the individual may be protected, assuming they were trained and it's tight fitting and they have a proper fit, but everything they breathe out is unobstructed. So I haven't gotten to the point where I'm gutsy enough to say something to somebody. And I understand that folks may not have access to, face coverings. So they may be just, any port in a storm. But there are many long-term care centers and most of our healthcare operations that would not allow this respirator to be worn, even though it's an NIOSH-approved N95 because of the exhalation valve. So some folks have sealed them, taped them, they put a coffee filter in, they put a paper towel inside, just as a way to assure that exhalation, that exhaled air, is barriered in some way. In terms of the nomenclature, NIOSH has a rating system for all filtering face pieces. They use one of 3 letters and one of 3 numbers and can be manufactured in any combination. The 3 letters are N, R, and P, and they apply to how well the filter is designed to stand up to oil. We know that oil can kind of gum up the works, can degrade the material. So manufacturers have to differentiate those styles that are resistant or oil proof from those that are not. And that's what the N and the R and the P stand for, either not resistant to oil, hence an N, an R meaning resistant to oil, or P for oil proof. The good news is, since you are working in an atmosphere that does not have oil mist, or we would suspect it should not have oil mist, you can use any letter designation. Notice that K is not identified on here. I'll talk about that in a little bit. N, P, or R, any would be acceptable. There are 3 numbers that correspond to this filter membrane as well that have to do with the efficiency of the filter as tested in a laboratory to be able to stop particles 0.3 microns and larger. The 95 series simply means that it's at least 95% efficient at removing those particles. 99%, and the 100 is the HEPA, or as we say, 99.97% efficient at removing those particles. So inevitably, somebody asks me the question, and I'll answer it even without you asking, is, well, how does this work? A particle, I know that a virus particle is smaller than 0.3 microns, maybe 0.1 or less, and you're only stopping 95 of 100 of them, so 5 get through. Could I potentially be breathing in, even wearing it appropriately, literally the thousands and millions of virus particles? The answer to that is, empirically, we know that healthcare providers that are wearing this level of respiratory protection are not contracting the disease. Really, it's attributed to primarily 2 factors. One is that virus particles, while smaller than 0.3 microns in theory, do not tend to exist singularly as a virus particle. I mean, unless you're into some aerosol generating capacity or specialty research, chances are we don't see virus particles. They attach to things. They bind to respiratory droplets, dust particles, fibers, et cetera, which tend to be larger than 0.3 microns, so they get caught. Secondarily, there's a principle in physics called Brownian movement, which has to do with the movement of ultrafine particles through air, which basically means they kind of bounce around like this. They just don't straight line. They tend to float and vibrate, and because of multiple layers of that material, eventually they get caught into the mix and they get stopped. So we do know that they work, even though they're not 100% effective, 100% efficient at removing particles. But for example, when we're dealing with carcinogen, we would never wear a 95 series. We would deal with a 100 series. If you're an asbestos worker, you'll wear a P100 respirator because we want to assure that not one fiber can get through. Surgical masks are not respirators. Again, they work on an entirely different principle. They're not tight sealing. They're not designed to filter 95% of the material. They are simply provided as a protection for the wearer to not spew respiratory droplets during talking and sneezing and coughing. Secondarily, they minimize contact, hands to the face. You don't tend to touch your nose or mouth when you have a mask on. So that's the principle. They say, you know, I wear my mask to protect you, you wear your mask to protect me. Again, they do work to stop disease spread, but not because they're filtering virus particles from your breath, but simply they're stopping respiratory droplets. And for all of the next set of slides, you know, there's the regulatory rules. I said the times they are changing, right? Because what I said a year ago does not hold true today. We used to say use only NIOSH approved respirators. The KN95 and other respirators that are approved in other countries are being allowed to be worn. In fact, the respirators that you will be issued are KN95 respirators from 3M. So they're not certified by NIOSH, they're certified by the Chinese government with a standard very similar to NIOSH, filter material that is very similar to what we wear. It's just a different standard and a different design. So KN95s have kind of gotten a bad rap, and we've seen it in our practice. Failure rates for fit tests are higher with KN95s, primarily due to the design. You'll see these have ear loops versus head straps, so it tends to be a little more difficult to get a tight seal, even though the filter material itself is effective. The other is that we just seen a lot of quality assurance and quality control issues as product has come from China. We're not dealing with name brand manufacturers in many cases, and the quality is just not there. We've seen them, you know, fall apart. One ear loop is 1.5 inches bigger than the other. So they're, you know, there've been a lot of problems with them. Now, the good news is that you guys have legit 3M KN95s, that they are very effective at passing a fit test. They're not the normal ones that we've seen, kind of the junk models, but they are legit and do seem to be very effective. We used to say you use your N95 once. Now, many of people, even in patient care, are using them 5 days in a row, storing them in a brown paper bag between uses. We used to say they're disposable. Now there are decontamination systems. You may be familiar with the FEMA-supplied Battelle system, which uses vaporized hydrogen peroxide, and a couple of Connex boxes are shipping containers connected together. They put in thousands of N95s, hang them on racks, flood the thing with vaporized hydrogen peroxide, and they come out clean and sanitary and ready for reuse. That just wasn't a thing 6 months ago. Now it's a thing. People are baking them. There's a study from Stanford University which talks about the efficiencies of putting an N95 in an oven for 157 degrees for 30 minutes, and they've demonstrated that it disinfects the respirator at least for a couple of times until eventually the elastic fails. There used to be expiration dates. And in many cases, they're saying use them beyond the expiration date. Used to have an annual fit test. OSHA has waived that. So there's a lot of relaxation in terms of the rules. What are the rules? And again, this is from an OSHA perspective for private sector. Anytime you have a respirator, you have to have a written respiratory protection plan. We have to have a plan for what we're giving people and what we're expecting them to wear. So this plan, this document would include the style of respirator, type of training and how often, when and where respirators are required to be worn, administrative duties of individuals, how we selected and used those respirators, and most importantly, medical clearance. So We do know that prior to being worn, you have to have medical clearance to be able to wear a respirator. A physician or other licensed healthcare practitioner would have had to sign off that basically says you're not going to get hurt by wearing this. And, you know, and you're going to go to long-term care centers. We're telling people to universally mask. There's just people that cannot physically wear a mask, either because of dementia, because of physical limitations. And there are workers that are just not capable because of, you know, underlying health conditions or whatever the reason. So as part of this, you had to go through a medical evaluation to be cleared to wear a respirator. We're then doing training, and then we'll culminate that with fit testing. So in terms of the evaluation itself, anytime you're wearing an N95 or higher, medical evaluation is required, because we do know that it puts a burden onto your body. Breathing all day through that filter material is going to make your heart work. It's going to make respiration increase, and it's going to put a physical demand on you that we want to make sure you're not at risk of. So you filled out this questionnaire. You guys have done it through the 3M site, probably. I think the state contracts with a group at 3M to be able to do that. Your results are confidential, and they're provided only to you. Your employer is notified that you're cleared or not cleared. That's it. How you answer those questions are really kept between you and the healthcare professional. Training is obviously what we're doing today. We talk about use, storage, disposal, signs, symptoms, limitations. And lastly is fit testing. In order to know that this respirator works, we must have assurance that we have a tight fit, and that is not a subjective process. There are 2 OSHA-approved protocols for fit testing, and in order for us to do that, we can't test anybody that has a beard or facial hair, and we'll talk about what that is in a second. 2 styles are quantitative, think quantity, a number, an empirical measure, a calculation, or qualitative, quality, pass, fail, yes, no, good, bad, like a binary choice. In terms of each of these, the quantitative fit test shown here in the photo uses a device called a porticount, a particle counter, in 2 tubes. One tube that's connected to a probe inside of the facepiece that's measuring the atmosphere inside between your mouth and nose and the facepiece, and one that stops just short that's measuring particles outside the facepiece. So it's counting both particles simultaneously, and it's a simple math equation. If there's 1,000 particles of any kind, doesn't matter what they are, 1,000 particles outside, and there is 100 particles inside the mask, then you have a fit factor of 10. You would fail the fit test at that point. But we're actually measuring for that style and size respirator what the particles are counted via the inside. That is really not happening. This is not happening regularly for a couple of reasons. This piece of equipment is about $12,000, so it's fairly limited into who has them. And secondly, and more importantly, in order to fit test, you room that respirator. You punch a hole in it in order to connect that tube. And given the supply shortages of respirators, we just can't waste any that we have in place. So that is not very common, although it would be acceptable. What is far more common is the qualitative fit test, this pass-fail test. And again, a couple of styles. We would use a product called irritant smoke stannous chloride, which forms a little acid when you get it in your throat, making you cough, an involuntary reaction. We only use this for P100s, though, for those respirators that are at HEPA, because even a small number of those particles can make you cough in an N95, and we wouldn't know for sure if it fit. So what we're administering is what we call the taste test. 2 different agents. You can use either one. One is a sweet saccharin solution. One is a bitter a product called Bittrex, which is made of benzoium benzenate. And that is, stuff we put on, they put it on kids' fingernails and their thumbs so they don't suck their thumbs. It's a non-toxic substance, but it is deemed the most bitter substance in the world. It gives you a real nasty taste in your mouth, so you know it when you taste it, kind of a thing. So when you do get the fit test, we'll ask that you don't eat or drink or smoke 30 minutes prior to the test. That's to assure that you have kind of a clean palate and that you will be able to taste this. We'll do a visual assessment of you wearing the respirator, make sure you do a seal check. And then you'll take the respirator off, no face mask. We'll squirt that solution in a hood. You'll breathe it in, get it on your mouth and tongue, make sure you can taste it. We have to have a sensitivity to make sure that you have the ability to taste it, because if you didn't, we would never know if you passed the test. Then you wear your respirator and essentially go through the series of exercises, and at any point in time you can taste it, then you failed the test. We can readjust or try a different size, but ultimately if you can taste it, then you would be breathing in potentially respiratory droplets. So we wouldn't want to give you that respirator. This is a quick 2-minute video on how to put on and wear the respirator. So this should play for you automatically.
Wearing a mask for work, the following steps can help you correctly put it on and take it off to keep yourself and others safe. First, wash your hands thoroughly and inspect your mask. If it appears damaged, do not use it. After inspecting the mask, cup it in your hand with the nose piece at your fingertips and the straps hanging below your hand. Next, lift the mask under your chin with the nose piece up. The top strap should go over and rest at the top back of your head. If you have a second strap, position the bottom strap around your neck and below your ears. Be sure not to crisscross the straps. If your mask has a metal nose clip, place your fingertips from both hands at the top of the clip. Slide your fingertips down the sides of the metal strip to mold the nose area to the shape of your nose. Now you need to check for a proper seal. Place both hands over the mask and take a quick breath in to check whether the respirator seals tightly to your face. Keep both hands completely over the respirator and exhale. If you feel leakage, there is not a proper seal. If the air leaks around your nose, you need to readjust the nose piece. If the air leaks at the mask edges, readjust the straps along the sides of your head. Take these steps until you get a proper seal. If you do not have a proper seal after repeating the steps, ask for help or try a different mask. Once your mask is on with a proper seal, do not touch it. Before removing the mask, first thoroughly wash your hands, then reach up and pull the strap over the back of your head without touching the respirator. If your mask has 2 straps, remove the bottom strap first, followed by the top strap. Discard the mask in a waste container and again thoroughly wash your hands. Following these simple steps will help you properly put on and take off your mask and keep you and everyone else safe.
Okay, so that's a little primer on that particular style of respirator. Again, there are a few different styles and configurations, but generally they'll, correctly worn, there'll be a top and a bottom. The nose piece will be at the top. The straps will be not crisscrossed. It obviously won't be around your neck. Kind of look for a strap going up over the ear, one around the neck, nice tight seal at the bottom, and then mold it to the nose piece. The positive and negative pressure checks, difficult to do, but generally that's what you can do in the field to be able to assure you're not going to have a fit test. You're going to have to do that positive and negative check every time you put the respirator on to make sure that you're getting a good seal. And again, for those of you that have facial hair, we're looking at this area around the face to be clean shaven. no more than 24 hours growth. There are some styles of facial hair that do work, and apparently they all have names now. I didn't realize all of that, but those are anything with facial hair in the ceiling area is not going to be acceptable. Last section, and I just close quickly, is in regard to bloodborne pathogens. And again, you're all healthcare providers, so I'm sure you've had a number of bloodborne pathogen training sessions, but we wanted to review a couple of the key points as we close, just to make sure, because we do know that SARS-CoV-2 is spread through respiratory secretions, so we're talking about transmission through bodily fluid exchange. Bloodborne pathogens defined as those organisms that cause disease in humans that are present in blood and other bodily secretions. So, we're thinking in terms of hepatitis and HIV, although those are certainly not exclusively the only bloodborne pathogens. This is essentially a bodily fluid exchange that you would be inhaling respiratory secretions and thus being contaminated or infected. So in terms of modes of transmission, when we think blood, we think needle sticks, right? There's 600,000 people every year that get stuck with a needle or a sharps. Sometimes they're healthcare, other times they're in housekeeping. Could be just contact with mucous membrane. I had a local university, an instructor who was squirted from across the room by a hypodermic needle after it was used in a vaccine educational setting, kind of transmitted across the entire room and caught her in the corner of the mouth. So, the exposures don't have to be in close contact. And of course, when we talk about decontamination, we're looking for use of an EPA registered disinfectant. So what is contaminated is the presence or reasonably anticipated presence of blood or other potentially infectious materials. And again, that's what we're dealing with. Test question for sure is universal precautions, right? We should know that we can't differentiate people that are sick or diseased, that have hepatitis or HIV. We treat all blood and bodily fluids as though they are infectious. And we will see, the use of a variety of things, including those hierarchy of hazard controls that we talked about. The primary concern from an OSHA standpoint is the hepatitis, particularly hepatitis B, because there is a vaccine requirement inside of that standard or a declination, but certainly stretches to other diseases that are a result of contamination. In terms of what needs to be in place, an exposure control plan, a plan to prevent people from being exposed, not unlike what is being administered by the Secretary of Health for businesses that are coming back, or colleges and universities and schools, to have a health and safety plan that talks about training, signage, engineering controls like self-sheathing needles and sharps containers, air filtration and negative pressure rooms, work practice controls like we've seen administered before that minimize the chance of exposure, from prohibiting eating and drinking in certain areas to establishing laundry protocols for how hot and how long something is laundered, to hand washing. Again, same kind of protocols we see in place. If there were spills or cleanup that has to occur, that there is PPE available and utilized for that. Use of a registered disinfectant or a bleach solution and the removal and disposal of PPE. Now, most of the PPE you're going to be wearing is disposed of as regular trash. It is not contaminated, grossly contaminated with blood or visibly soiled, so it will go in the regular trash. There's no infectious waste handling, although some of the sites you're going to work at will require red bagging of that just as a precaution. They're not differentiating. They're dictating that all consumed PPE be disposed of as a red bag waste. If it is red bagged, then it's got to be obviously leak proof, closed, sealed to prevent further transmission, and appropriately labeled. There are generation and disposal requirements of time, depending upon how that is treated once it's full. From 30 days if it's not refrigerated to a little bit longer if it's refrigerated or even frozen. In terms of an exposure incident, if you've had one or have one, and I have not, but I got to imagine these are incredibly traumatic. It's kind of standard. Get as much of the immediate action as you can. Wash it, soap, water, flush it, copious amounts of water, minimum of 15 minutes. If it was in your face, irrigate that area. Move as much of the bulk material as you can, as fast as you can. And then as part of your exposure control plan, there's kind of a clinical component of this, both in terms of a medical assessment. If you did have an exposure, if you had a needle stick, if somebody coughed on you, sneezed on you, whatever, you may have questions for the physician. When should I be tested? How long should I be tested? What is the ability to test the other person? Can you identify the other person? So there's some medical questions that are provided for in a medical assessment, as is their counseling. This is incredibly traumatic. You can imagine, in a needle stick situation where you have to wait maybe 30 or 60 days to know whether or not you've contracted a disease. It's got to be incredibly stressful and traumatic. So there's some counseling built in as a part of that. That essentially completes our session for today. I'll close with a few slides on kind of what to expect for the second part of the training when you do show up for the hands-on. So kind of even before class, we will be doing fever screening. There will be one of our staff who will be taking temperatures. We'll ask you some basic health questions that you're asking probably many of your employees and staff. We will be wearing face masks. We have selected sites that will allow for appropriate social distancing. We'll have 2 people at a table, 6 foot apart, big open spaces, gymnasiums, cafeterias, big classrooms. And of course, I assume you're not coming to the session if you're ill. And if at any point in time you feel ill during the session, notify the instructor and just leave. It's not that important. We don't want to be responsible for further infecting 20 of your colleagues or 19 of your colleagues in the class. We start with a quick review of today's session and completion of a quiz. I think it's like 10 questions. We just kind of review that relatively quickly to make sure we've purposely made the registration part of this easy. We didn't collect names. We didn't make you register or sign in. We take care of that when you're at the in-person session. And then we're going to do the fit testing. So you'll get a form. We'll complete fit test form for every respirator. Some of you may have multiple respirators that you're being issued. If you have your own respirator that you want to use, you can bring that. We'll fit test you. It's important to know that you're fit tested on the make, model, and size of a particular respirator. So, you know, if you've got a Kimberly-Clark duckbill regular, that doesn't mean that you're a regular in the 3M 9501. That test is specific to that. So, well, we have 20 people in class. We may be joined by other individuals who went through previous classes, but are just now being assigned a new respirator, a different style. And then at the end of the session, the last hour is kind of dedicated to the trainer. So if you're a supervisor for the Department of Health and you're going to be responsible for fit testing moving forward, we'll just spend some extra time with you. We'll go through the protocols in a little greater detail. We'll let you do a couple of fit tests so that you will be able to be familiar with the process of conducting a fit test at the end of class. Fit test is the last component, so we would be doing donning and doffing. Some of you may be done in as little as 2 hours, depending upon if you're first to get your fit test, and others, you know, maybe stick around for the full 4 hours if you are, you know, being a fit test trainer. So just for planning purposes. Close with a couple of you know, informational slides. I did put my contact information in the chat box, but our contact at the Pennsylvania Department of Health is through the Bureau of Emergency Preparedness and Response. Eric Lammer, who was the individual who emailed you probably the registration information and medical clearance. That's his phone number. And then our program, again, is developed under the direction of our principal, Dr. Joe Cacciardi, who is a person responsible. And again, we're a subcontractor through the health department. So that concludes our session today. I thank you for participation. I will happily open up the lines if anybody has a question. You're welcome to use the chat feature or just unmute your microphone and ask away. Otherwise, you are free to go. And please do, if you've registered for a class, please do attend or notify Eric as soon as you're made aware that you're not going to be able to make it. We're restricting participation to 20 individuals. So if you take up a slot and then back out at the last minute and no show, somebody else isn't getting to that and may have to, you know, drive from Clearfield to Greensburg or to Williamsport for training. So please don't no show. If you can't make it, you can absolutely just notify Eric and he will make us aware. Maybe he can bring somebody in off of the wait list. Thank you and have a great afternoon. This will end the recording.